many other, there are many other enabling factors which promote this research. Factors like funding, accessibility to expertise, collaboration with global researchers are only a few such examples. These enablers allow us to undertake competitive research problems, increase research output, streamline its relevance, disseminate and make it accessible to public at large. In this webinar series, we will invite representatives from such organizations who enable and provide opportunity to us to do value-added research. Today is the first session of this series, and we have Harish Iyer from Bill and Melinda Gates Foundation with us. Welcome, Harish, and thank you for being here. We also have the IGIB researcher community here with us, so welcome to all of you too. Let me briefly introduce the speaker here. Harish Iyer is the Deputy Director, Digital and Health Innovations at Bill and Melinda Gates Foundation, working out of the India country office. Harish is interested in the role of innovation, science, and technology in improving public health and equitable economic development. He is a strategic partner between Indian researchers, global partners, and the foundation teams in critical R&D work, including in vaccine preventable diseases, new approaches to treating neglected diseases, life science partnerships for public health, digital health innovations for all, and reducing the digital divide. Excuse me. Prior to his role at the foundation, Harish was the CEO of Shanta Biotech from 2011 to 2015. He has also worked in various R&D roles in several biotech companies, including as head R&D of Biocon and in various technical roles at Biogen IDC and Genentech in the US. Without taking any further time, I would hand over the forum to Harish to learn about how BMGF works and how we enable the research over there.
Thank you so much, Aradhita, for the kind welcome. So today I will have a sort of a high-level presentation on how we work at the Gates Foundation, the areas we work in, how we fund, some sense of the overall quantum of funding we've done globally and within India. So hopefully we'll get a very different sense of the areas we work in, and I'd welcome opportunities to answer any questions that I can. So very briefly, the outline of this project will be starting with one slide on SDGs, which will have some introduction to the Gates Foundation, introduction to the Gates Foundation, how we work, how we think of ourselves, our work in India, some ideas around how new tech can impact our goals, and how we fund projects. So as many of you know, SDGs were adopted by the UN General Assembly in 2015, and the health and well-being SDG goal number 3, which is around how to reduce MMR, IMR, how to prevent or end epidemics of AIDS, TB, malaria, NTDs. All of this, and also looking at sexual and reproductive health care services, which we call family planning, and looking at universal health coverage. All of these are key goals for the foundation. So the focus, if you can see on the left-hand side of the slide, the focus is on reaching specific sub-goals in a specific period of time in key geographies, because Bill and Melinda, when they allocated this money, were keen that we have time-specific critical goals that we could meet. So BMGF, and you'll see this theme a little bit over and over again, works in close alignment with Government of India's health goals. The particular strategy we focus on is often where the organization has expertise to support development. We call this our theory of change. This is sort of the language that we use inside the Gates Foundation. How do you think change will occur, and what change is needed, and where we can do? And these kind of strategies are often presented to Bill and Melinda, who are currently the co-chairs of the foundation, and they decide how much funds can be allocated from the available budget. Obviously, in an emergency like COVID that happened last year, this is outside the normal in quotes, normal kind of work that we do. It was something very unfortunate, but also very special. So significant monies were allotted for COVID as a special case. And then over time, we have operational reviews of grants, investments on a regular basis to understand progress. And I will share a little bit of how we think through this, a little more detail I'll give towards the end. So what do we do? The foundation basically has 4 missions to help a vision of the co-chairs of a world where every person has the opportunity to live a healthy, productive life. Fundamental to it is ensuring children, babies, and young people survive and thrive. So you will see that a lot of focus on vaccines, nutrition for the newborn, for maternal child health, essentially a way to increasing life expectancy and reduce the morbidity. And you will see Bill and Melinda always talking about this. In particular, a lot of the focus is on the poorest, especially women and girls who are often marginalized in many societies. Just to note, of course, they do this similar kind of work all around the world, but India is a key country for them. Also combat infectious diseases that particularly affect the poorest. Before I came to the foundation, while I'd worked in India for many, many years. I did not have a great sense personally, even though I worked in the healthcare field, about what diabetes was and what's the extent of diabetes. And I've even heard, Soumya Swaminathan talk about even her family not knowing much about TB till she started working on TB. So it is really a serious problem about communication and bringing awareness to people's lives. And of course, Bill and Melinda hope to inspire people to take action. They will often work with philanthropists around the world to see how they can also support such projects. How do we do this work? We work with grantees and partners who are completely at the center of the work. The foundation itself does not have any factory or any R&D lab by itself. Everything, we're primarily a funding organization with a particular strategic aim. And so grantees and partners are at the center of our work. And then obviously major push is to harness the power of science and technology. As many of you know, we are working on a couple of very exciting projects that IGIB is involved in, and I can maybe mention that briefly as we move along. And our work obviously requires support from governments, private sector, communities. We actually do quite a bit of work with SHGs and NRLM in Bihar, the National Rural Livelihoods Mission, which works primarily with SHGs. Non-profits, obviously, organizations like PATH, MSF, and others, and also with individuals as needed when they have specific expertise. People often ask us, who are the folks you do the most amount of grants to? So I thought it would be useful to see this slide. The number one grantee of the foundation in dollar amounts has been Gavi, the Vaccine Alliance. A lot of that money going into procurement of vaccines for poor countries. For example, if you say PCV or rotavirus introduction, or looking at research into malaria vaccines, a lot of that has gone through Gavi. Also, health system strengthening has been a big part of our funding of Gavi. Also funding WHO to a significant extent. PATH, which is a not-for-profit organization in Seattle called Program for Appropriate Technology in Health. There's a PATH office in Delhi as well in terms of looking at new technologies. How can we do more? PATH does a lot of work in diagnostics devices and things like that. The United Negro College Fund, this is primarily in the US. The Global Fund, UNICEF, Rotary Foundation, a lot of work around, obviously, polio vaccination. Johns Hopkins is the number one funder from our perspective in terms of universities. It has a wonderful MPH department, so they do a lot of work and research projects around the world for the foundation. The World Bank, and this was at the time when ERAS was still there. Obviously, we had spent significant amount of money on the TB vaccine through ERAS. In 2019, just to give you a quantum of the amount annually, the foundations invested about 5.1 billion. For example, last year, this amount would have been significantly higher, I think closer to 6.5, because we spent a lot of money also on COVID and COVID-related projects, which doesn't come into the normal spectrum of what we do. But it may be there now quite a bit into the future. So here, the divisions we have, there's a division called Global Development, which is the office in which the India office sort of sits in, where it's primarily about healthcare delivery. How can we improve healthcare delivery? So it could be supporting the government on NTD projects, for example, lymphatic filariasis or leishmaniasis or PKDL or diarrhea or maternal childhood. All that delivery of services comes under global development, roughly $1.7 billion a year. Global health, which is the team that I sit in. So I have two hats. I sit in the global health team and global development team. The global health team is much more focused on upstream development. So early stage vaccine development, early stage new drug development. So for example, we funded significant amounts of serums capacity building for Covishield. We have funded in the past Bharat Biotech's work significantly on rotavirus. We have funded work with BioE on measles vaccines, rubella vaccines. How do we get higher quantities of these vaccines so it's available globally? But also looking at new drugs, molnupiravir or the new drug from Pfizer or other antibody work, a lot, new diagnostics, a lot of this kind of work comes into the global health division, including the work. It could also be work around clinical research, right? So for example, we are funding researchers to look at what happens if you have heterologous boosting, right? So you have 2 doses of Covishield in India. What happens if you boost with Covaxin or Covishield or some other vaccine, maybe Covavax or Corbevax or the new vaccine? What happens? What's the outcome of these? And then sort of help to build up capacity around it. Also, there's a couple of exciting projects that with IGIB, which I mentioned. One is on expanding genome sequencing capacity, where Rajesh is the PI for that from IGIB. But there's also another grant, which is the collaboration with IGIB and THSTI on looking at antibodies and antibody response to COVID and how different people react and the level of neutralization of different variants. So all around antibodies and sequencing and understanding how the human body sort of reacts and sort of creating that collaborative sort of environment. There's a group called Global Growth and Opportunity. That's the third on this list, which works heavily on non-health areas. So mostly around sanitation, financial services for the poor, agriculture, looking at how can we improve agriculture in a world where global warming is going to be more and more important. How can farmers get a better understanding of the market and prices and improving the information flow between farmers in the field and markets? That's a lot of that kind of work happens in global growth and opportunity. So the sanitation work is very much about how do you make sure you treat sludge, sanitation waste. Often this is dumped into wasteland and of course can be potentially a source of infection, especially if there are sick people defecating. So how do we improve that? And also supporting the Swachh Bharat program of Government of India. Then we have the global, the US program and something called Global Policy and Advocacy and other programs, just to give you a sense of how the funding is split up. Now, in terms of focus for India, India is a very important and priority partner country for the Gates Foundation, partly because of Bill Gates's own interest in India, because he had a lot of Indian employees working for him when he worked at Microsoft, and one could argue that they also helped make him the man he is today. But also a deep liking for India and the innovativeness that India brings to the global table. So roughly Foundation has committed $2 billion for health in India in cumulative since 2003. Significant amount went into the polio eradication program, polio surveillance program, vaccination, and I'll talk a little bit about some of the novel things that we're doing in polio since 2003. Also committed roughly $30 million for India's COVID response and an additional 300 million. This was through de-risking some of the scale up and manufacturing that companies had to do in India. And today we do grants for roughly 20 million per year in health. And in particular within India, we do a lot of focus of global delivery, at least in UP and Bihar. So those are the two states which we think we can potentially have the biggest impact. And those, again, very much focused on MNCH, nutrition, family planning, those kinds of areas, vaccine delivery and stuff like that. So, the challenge in India, of course, is the changing nature of disease burden. This was a slide from GBD that I got from Lalit Dandona, how the DALIs have changed over the years and how non-communicable diseases eclipsed communicable disease. So while we focus significantly on communicable diseases and maternal and neonatal and nutritional diseases, we've also started to think about a little bit about non-communicable diseases from a health system perspective. So, we are often looking at how do we support a health system, and you will see that we have a group in health system design that also works closely with government in trying to help government think through some of these issues, be a thought partner in a lot of this work. And I can talk about that later, but it sort of falls a little bit into a digital work, financing work, how to simplify financing of healthcare and so on. In India, the core areas of work are on the left-hand side table: MNCH, sanitation, nutrition, ag development, family planning, looking at contraception, FSP, looking very much at digital to improve access to financial services for the poor, vaccine delivery, women and girls, making sure this is a new program that has been there quite recently, tuberculosis, health system design, VL and LF, and innovation research. My focus is really on innovation and research, but you can imagine that it goes across many of these other divisions that are our areas of focus. And we focus very much on health impact indicators, reduction in MMR, NMR, SBR, U5MR, looking at modern contraceptive prevalence, increase in lives saved by nutrition interventions, and elimination of VL, LF, and TB. And if needed, I'm happy to talk through each of them in more detail. How do we address these issues? Obviously, in India, our efforts are aligned, as I mentioned, with national objectives. So for example, on the left-hand side, you can see, accelerating universal use of sustainable sanitation, focusing on safe management of human fecal waste, right? How do we design trucks or machines to make sure that, sanitation waste is processed in a way that the final output looks like almost drinkable water, right? How do you create those systems? Working with Ministry of Rural Development to see how can we integrate these into, as we build smart cities as a country, the importance of it, making sure that you have good dashboards for people to monitor. So that's just one example of what we would do in sanitation and the kinds of grants we would end up making in sanitation to enable some of this. Increasing productivity and incomes of smallholder farmers, increased usage of digital financial services among the poor, and of course, closing economic gaps and increasing women's and girls' power and influence. So often grants would be to ensure, specifically targeted toward women and girls, to understand, first of all, what they face as problems. As an example here, there's a cross-cutting between digital and women and girls' power, right? Often women do not have access to mobile phones. In a family, if there's only one phone, the men usually have it, or the young boys or sons might have it rather than daughters and mothers and aunts. So, trying to understand this behavior, but also trying to find ways of communicating directly to women on what their entitlements are, and then also certainly helping them make sure they can get access to those entitlements. So all this would come under the rubric of improving health, productivity, and livelihoods of Indian citizens. The other part of the agenda, you can sort of call it advancing India for the world agenda, which is about strengthening institutions in public health, digital health, science and technology, and other development areas, expanding Indian R&D and manufacturing for vaccines, diagnostics, therapeutics, and medical devices to meet domestic and global needs. And here again, some of the examples I gave you earlier make sense. And then also, trying to create these networks of collaborations, of course, around the world between North-South and South-South, and then ideally document and diffuse Indian best practices to help the world achieve SDGs. So from a health perspective, our focus is very much on prevention. So some examples I'm sharing on this slide. Obviously, at the core of all this is you do need a strong health system in terms of HR, financing, facilities, contracting, and access with equity. But in MNCH, as I mentioned, empowerment of women and girls, safe pregnancy. So we have multiple grants in UP and Bihar. on how do you improve pregnancy experiences. We work even on designing labor rooms. How can we have a better labor room? Practices, training, midwifery, training, nurse mentoring to improve, training that nurses get in many of these facilities, often hands-on training, neonatal care and protection, key aspects during intrapartum. What should one do? Well understood WHO guidelines, Ministry of Health guidelines. How do we make sure the implementation is better? Looking at evidence, and of course, protection from illness through vaccines for both the mother and the baby, right? How do we make sure the coverage is there? And then tools to monitor coverage and making sure how coverage can do better. Obviously, when babies, very much focused on neonatal infection, respiratory distress, diarrhea, common, well understood where we can maybe make an intervention to improve. Nutrition, very much focused on improved diet diversity and appropriate food intake. There was a recent study called the WING study, which I don't think the results are public yet, which we worked with SAS in urban slum in New Delhi, looking at what happens when you improve nutrition to mothers and babies, post 6 months. How does it impact, early low birth weight, early for, early, not at term birth, or looking at stunting at age, 12 months or 18 months or 24 months. How does nutrition impact some of this? And, doing research around that. Appropriate diagnostics and therapeutic treatment, looking at availability of diagnostics. Diagnostics is an area where we're relatively new in India. We've certainly struggled a little bit to understand how exactly it could be placed in India and who key partners would be. So we've not really pushed it too much. It's early for me as well. But certainly on medicines, trying to understand what medicines are available at PHCs, at district hospitals, and really quite a bit focused on the public system. While we recognize that the private system is also important, for significant effort is done on both private and public system. Disease surveillance and modeling, public health, early warning signs for public action, government response. I would argue that some of the grants to IGIB fall in this bucket. And of course, health prevention, disease, and financial information flows via ICT systems. Here, a lot of the work that my cluster does, which is the Digital and Health Innovation Cluster, is working with the National Health Authority in closely to provide technical support as needed by the government to, for example, implement Ayushman Bharat Digital Health Mission as an example. How would we work on it? How do we provide technical support to implementing it in key states? Some examples of innovation, just so you all are, what I'm talking, understand what I'm trying to talk about. In R&D, it could be data generation to understand disease burden, new vaccines I mentioned already, new drug discovery, new therapies for HIV, TB, malaria. Again, focused, just as a quick example, TB could be, can we find a single cure, a new cure for TB, where you don't have to waste time testing for susceptibility? Is that possible? Because often people get on the wrong therapy for some time and then they find out that the susceptibility tests failed and then they have to switch therapy. So, things like that. How can we simplify delivery of therapy is a key idea. In TB, of course, vaccines as well, the M72 vaccine and, potentially new mRNA vaccines in TB are things that, sort of we are working on right now. Same thing true for malaria. How can we get quick cures? Are there ways to cure host-directed therapies and things like that? Basically, that's the broad idea in looking at drug therapies. And of course, COVID also, we tried to fund multiple drug therapies, whatever works as quickly as possible. How can we get into the hands of the people who need them? New diagnostics, new area for us, but idea is basically to find things that are easier to use in public health. What are the right kind of studies that need to be shown, that need to show if a diagnostic is useful or not? Great examples here would be, like the multiplexing assays that, or the gene expert type of assay that India has used significantly also during COVID, similar cartridge-based assays from other companies. And of course, new biomedical devices. You see on the right-hand side, you can see this Butterfly IQ, which is a handheld ultrasound. First of all, ideally trying to do this within the Indian industry because we want to make sure that it is usable, and also trying to understand what's the value proposition. Is it basically, do we get early reads on poor pregnancies? I mean, this is very much focused on pregnancy at this point. Do we get an early read on poor fetal growth and therefore are there interventions that can be made, right? So that you reduce the risk when the baby is born, or either stillbirth or any other risk to the mother. In terms of capacity building, some examples are we do have clinical research fellowships, which are, I think, very important for researchers to be able to travel between India. And in this particular case, I'm referring to an ICMR fellowship, which we have co-funded along with NIH. There are research networks we are trying to support. The Geyser network that IGIB and THSTI are part of are examples of this. So there is broad collaboration internationally and locally, and these networks can hopefully be strengthened. So there is great capacity being built in the southern countries, in the LMICs, if you will. And there are, of course, countries that do not have this expertise, where India has got quite a lot of expertise in this, but there may be other countries in Africa that don't have. So really trying to encourage collaborations. I think it's been working quite well. I've attended some of the Geyser calls, and strengthening modeling capacity and capability, for example. So, for example, I've often heard IHME, just an example, IHME may be doing a model, but researchers don't fully understand what's under that model. So how do we build capability within country on understanding this and coming up with our own models with our own data, so we have much more control over what we're trying to do. So that's the idea there. And in digital innovation is really about digital data for health to improve decision making. For example, you can see ArguSoft MedPlat on the bottom right as an example of a frontline worker app, and now actually a platform that UP government, this is a public digital good that's been developed, and governments can feel free to compare this to other platforms that exist, see what's useful, and then do what's appropriate for the citizens of the country. Immunization support, we did support aspects of troubleshooting and development for COVID, which many of you will have certificates from for your vaccines. It's been a tremendously useful thing for most people, I would believe. And improving compliance and treatment, using digital apps. But all of this, a core aspect how we work is use feedback and data to rework strategies, learn from the field and adapt, because there is no simple linear pathway to how impact is felt in the field. So often we are doing things like that. I want to show a few more slides on some new technologies that we work on. For example, improving manufacturing is something that we've spent a lot of money on, reducing cost of manufacturing, simplifying delivery, key aspect of it. How can we simplify delivery, multi-dose vials, new preservatives, RNA vaccines. This is something that we started working on very early. Of course, mRNA vaccines are quite big now, but when we started working on them, they were really, really early stage. Other ideas include modifying existing oral polio vaccine. The reason why is oral polio vaccine a problem today? Because the oral polio virus, the vaccine, the attenuated virus, goes into the environment and then starts to multiply and revert back into virulence. Could you make a safer, more modern oral polio vaccine that is unable to revert to virulence, or the probability of reverting to virulence is much, 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 much lower? And could you use it in case there's an outbreak? How are we thinking about this? So this is a vaccine that we are again working. We worked quite a bit on this, and now we have a grant to BioE to sort of see how they can be a backup in case in the post polio eradication era there is a sudden outbreak. How do we quell that outbreak quickly? And we believe that oral is a faster approach than obviously digital, than injectable. Here are some more examples of improved manufacturing, lower cost, simplifying delivery. This is a company that we did some funding with called Univercells, where they're looking at high density single-use bioreactors that could potentially cut cost of manufacturing polio vaccines down to 15 cents a dose, which is incredibly low price. But the idea is to how do we make this thing widely available? All our grants that we work on always have this universal access clause and pricing and making sure the prices are low to the countries that need them. Other ideas include multiplexed, easier to use and lower cost diagnostics. This is something that I'm hoping to work on more in India. But as of now, have not done too much on it. We're still in an early stage of discussion on what we can do. Other examples are, this is another set of examples. COVID, I already mentioned on the left-hand side bottom, digital delivery of vaccines, simplifying delivery with something called the blow-fill seal, which is basically a single device, very inexpensive, that can contain a particular product and a needle right next to it. You can see the picture. The vaccine vial monitor, which many of you would be familiar with, was originally funded by the Gates Foundation through PATH. It tells you in countries that do not have great cold chain, it lets healthcare workers know if what's inside the vial is safe to use or not. And in the top left corner, this is a little more fantasy land in terms of what could be possible. For example, can we create formulations that can last a week rather than a day, and therefore simplify or improve adherence to drugs, for example, like TB drugs, right, where they have taken for months on end and people forget, and it can simplify their life in terms of taking up drugs. We also, another method of working is we also crowdsource ideas through global things called grant challenges. This is just an example of a global grant challenge that we worked on, where we put out calls for grants with specific questions. Can you come up with solutions for a particular project or a particular problem that we face, right? So, trying to understand how people in the field think about it and who is interested in working on this. Are they looking for small funds? And so this was in 2019. This is AI, material science, wearable sensors, synthetic biology, all of these areas to see how can we bring cutting edge technology to the problems at the bottom of the pyramid, right? And these should be, of course, very important to note, these should be doable and should have practical public health impact. That is certainly the intent. So in India, often when we are reviewing proposals, we have a diverse independent group of people, including from academics from well-known institutions, who come together and sit through and look at, well, is this a reasonable solution? How can we solve this? I just want to point out one recent one. Recent is in 2-3 years ago. Last 2 years have been all COVID. Was on how do we deal with antibiotic waste in pharmaceutical effluents and sewage and hospital effluent, right? AMR is going to be a big challenge for us in the future. How do we deal with that? What are the ideas? Just other ideas on examples of global grant challenges, or even India, the grant challenges, India program. Ideally, trying to ask the right questions is the other approach we take. Let's take a simple example of barriers to primary care, right? What are to try and fundamentally understand what are the health-seeking behaviors, what is the out-of-pocket fees, what is the gender equality, social inequality, how do we make sure, is it women-centric, looking at the distance you have to travel, so basically thinking about ambulances and how do we make sure we think about that in a health system design, what is the availability of skills in the primary care setting, and quality of care, and ultimately care. Last couple of slides, how do we fund projects? There's something called concept development. So as I mentioned at the beginning of the presentation, we have a strategy where we think we can be useful in a country. Based on, and this is basically what the co-chairs agree, is that where we think we can be useful. And then ideally generate ideas and identify applicants. So we often go out and look for applicants who we think would be good, and therefore it's important to continue to have these dialogues. We develop, analyze the proposal, the funding decision is determined, and we develop grant agreements. And the grant agreements often have requirements such as you cannot lock these things up behind IP, ideally. You have to share data globally with other scientists. If you making a product, you have to make that product available at low cost at a particular pre-specified cost or price to global people. So for example, any vaccine grant we would do, or a pharmaceutical grant or a diagnostic grant, would have certain pricing ceilings that you cannot price above this, to make sure that it's available at an affordable cost. And that's the point of this philanthropy. And of course, once the grant is done, we manage the grant and measure progress against it. This is my last slide. I think some of you may not have seen it. Obviously, technology has dramatically transformed the world. This is Harish, my point of view. It has a significant opportunity to play a role in health. But keeping in mind, this I tell my colleagues inside the foundation, and I share outside, technology is not a magic bullet. It must be enabled and be accompanied by other social change, which often depends on society itself. And safeguards are important, and protections are very important for the vulnerable and the marginalized. It's important to understand how markets can be created for technology in health. We know technology is important because obviously all of us use technology in our everyday life. We have access to medicines, we have access to diagnostics, we can measure quickly, but people often at the bottom of the pyramid struggle with this kind of effort. So how do you make sure everybody has the equal quality of care is the key question here. And we know that there are significant failures at the bottom of the pyramid. Clearly, a poor person in our country cannot get the same kind of help that a wealthy person can. So that's a big challenge. Financing for technology procurement and public health needs to be well thought through. Foundation can do things like investments that play a role in the push function. So early catalytic inputs. But of course, the health system should, do health technology assessments, which are critical to build confidence. And we support health technology assessment as well. So it's like a virtuous cycle that is needed, where all products that are built must be continuously evaluated for effectiveness in the field. And a virtuous cycle of feedback, we believe, is needed between citizens, communities, and researchers, which will really help all of us, jointly do better on this front. So I will stop there. I hope I have not taken too much time, Aradhita. I want to take about 40 minutes or so.
No, that's absolutely fine. It was a real enlightening talk. And I remember the first time we conversed, I was talking about this, that I want to hear from you how what BMGF does and how it works and kinds of things like that. I would request
hopefully you got a
people
sense
here.
of, so Aradhita, hopefully all of you all got, and Anurag as well, I hope you got a sense of how we work. And I think you might have heard some of this before, but in case you haven't, I hope.
It was wonderful. It was very good to get a very detailed sense of how the process of the entire system is for you. And I think it was very useful for everybody.
Thank you.
If anybody has any questions, I would request you to either raise hand or type it in the chat box. Sorry. My camera decided not to work today. Sorry about that. So while we have somebody, I'll take the opportunity to ask you something, Harish, if you don't mind.
Please.
You were mentioning about the clinical research fellowships. So I understand you said about the ICMR and IH1. Could you tell a bit more about these fellowships, how people can, the students here can avail it? And, yeah.
To be completely honest with you, this has not been announced yet. So just sort of mentioned it ahead of time. The idea would be that, let's say in this case, it could be NIH and ICMR working together, and then hopefully a call will come out. My understanding is that there's more of an agreement on it, but that's just an example of what we could do. We have done with NIH in Africa, for example. We have also done in the UK. The idea would be, again, it would be worked out between, let's say, two academic institutions, for example, right? In this case, it would have been between ICMR and NIH. I had talked to Dr. Bhargava a long time back about this when he first came on board. It's taken a long time to happen, obviously, but the idea was, how do we make sure that we can collaborate? And of course, the pandemic came in between and sort of delayed a lot of things, unfortunately. The idea would be pick specific topics of interest. And when the announcement comes, you will see it, and I will share it with all of you if it's of interest to you. Idea would be to see, are there areas of interest, common interest for a lab, let's say in the US at NIH, and let's say in India? Are there researchers? Ideally, our aim is to have young researchers, at least half women, half men, let's say, who can go and spend time in a lab in the US at NIH, and then ideally people from a lab in the US come and work in India. right, in a lab in India of common interest, right? It could be nutrition, it could be molecular biology, it could be sequencing, it could be infectious disease, it could be pathogen response, it could be many of the things that you folks are trying to do. Rajesh always is explaining to me the very fascinating projects that he's working on, post-response, co-infection. All these are, very much in my mind, at least, because actually it's NIAID, it's the big key player there. So, all this sort of falls under, I would argue, NIAID's, ambit. But this will have to be, so we, as the program officer for this project, I don't play a role in either announcing it or in any selection criteria. So it would be up to researchers in both organizations whom we are co-funding to think through about what do they want, and what specific topic, and interviewing candidates. And so I assume, again, I'm not part of the process, but I assume I will be an observer most probably, but I assume there will be a process by which people will get interviewed. And we want to do, ideally, we would love to do more of this. So this is a long time interest of mine, but it's still not come to fruition yet in the public. So I'm hoping desperately that one of these days you'll see an announcement, and then you'll remember this talk.
Right. No, I was just trying to find how to go about it, because there are initiatives where IGIB and other organizations in US, or say NIH, we are collaborating and working, and we would, like this kind of an exchange or having student training on either basis. I was just trying to figure out that if these fellowships could be availed by such people. And the second one that I wanted to ask was about the research networks. So JISER is one such where the South Asian region is involved in. Are there any other such networks, or if somebody has identified such a South Asian network or international network, could we approach for support?
We should have a call and discuss that specifically with people, because there will be many networks like this. I feel, I'm quite confident.
Yes.
There will be many. So obviously, for example, AMR, you could have a big network around AMR. Perhaps there could be I am not sure. AMR, I know we do quite a bit of work in, but mostly focused on prevention. Often disease surveillance is a network, often within the country, but if the data gets pooled at some point, you will get a pooled data and people learning from each other. So key aspect, international collaboration, certainly sharing data is critical, but also we do collaborations within country. There was a great collaboration that we did with Dr. Gagandeep Khan on rotavirus surveillance within the country. You bring in many institutions within the country to work together over a multi-year period to share knowledge. What did they find? And I've sat in some of those meetings. I come from industrial research, so not necessarily used to doing it in this format. It's such a wonderful set of, the energy is really wonderful in many of these meetings. We have a meningitis surveillance network within India that is, I think, through, King George's Medical University, I think, is the key PO for that, but multiple, including, hospitals, clinical research hospitals all over the country. So those are the kinds of things, we have tried to do. But I can get you a broader list, maybe if we can talk separately, because I'm not fully aware of everything. This is something that I funded, so I remember GISER clearly, and some of the within India networks, I remember, as I mentioned, disease surveillance and things like that. Yeah.
All right. Thank you so much.
So, Aradhita, if I can come in shortly.
Yeah, sure.
Thank you, Harish. I think this is also my first exposure to get a really big picture of BMGF. While listening to the talk, I was thinking that, which you call as investment, how much of a risk assessment goes into in terms of funding a proposal? So for example, surveillance is more of a, like, we know that there would be something coming out of a surveillance funded project, but something which is, say, not so direct, for which, so how does in terms of when a decision is being made that, well, this project probably deserves funding, how does that risk assessment goes into in terms of the outputs?
It's a very good question, but also a tough question, because everybody's assessment of risk is different. Obviously, for relatively smaller amounts, let's say less than $5 million, which is big by most standards, but at Gates Foundation, that's still a small number. The decision may be at the level of the president of the division, right? So I think, or even within the director of the country, right? For example, a lot of risks. So there are multiple types of risk. Right? One risk is in early stage research. So suppose, foundation invested, I think like 10 years ago or even longer on mRNA vaccines, on anything connected to mRNA, right? So we funded BioNTech, by the way. We funded Moderna. I think we even might have funded CureVac or Innovac or one of those companies, right? So you can see this is actually, but we didn't fund them for COVID, obviously. We funded them for TB and malaria, right? We didn't think COVID would show up. But for many years, nothing came out of it, right? Nothing came out of it. And somehow it's ultimately because it's a family foundation, the big amounts, Bill and Melinda can take, Bill and Melinda often, but in technology, it's really Bill. He can take a call and say, I think this is interesting enough. And depending on who you hear, who you listen to, right? Which, often what they do is get people to come and talk to them. So the leading researchers in the field often go visit Bill and speak to him and give him what's called a learning session. And I'm giving you some of the insider thinking, right? Inside what happens. Because he doesn't know about it, right? So they will teach him about what can happen in it, what are the likely risks, what are the positives, negatives, what could be the impact, what are the early results in these areas. And presumably then he takes a call saying, this is, I think, interesting enough that we should do some funding in it. We'll take a risk. Okay, we can take a risk. And often the kind of conversation we have is we can take more risk here than other institutions perhaps can take. Perhaps this is the theory, whether we really stick to it or not, I don't know, but perhaps we can. So I'll give you an example at a country level context, right? So there was a lot of discussion around should we be working in UP and Bihar in the very beginning, right? Are these the right states to work? How do we pick which states we want to work in India? So some people said, but maybe there is more risk in UP and Bihar. And some people said there is, but more benefit is possible also in UP and Bihar. So there was always this discussion on how you assess risk. And ultimately it does come down to making a convincing case for why it's worth the risk. No doubt there are areas. So nurse mentoring. So I'll just give you an example of nurse mentoring, right? So training, often nurses we find in hospitals come with a degree with almost no training, especially in the lower level, right? They essentially got a paper degree, almost no training. So you can argue whether can we train them in 3 months, 6 months, 9 months? Is it enough to be trained? Do they have the motivation to get trained? Will they get trained? So there are that kind of programmatic risks as well. And, it's something that we have to learn. And I mentioned in one of the slides that you often have to get feedback from the ground. Very, very important. How to measurement, learning, and evaluation. The MLE is a core part of everything we do. What is the hypothesis? Is very much like science. What is the hypothesis we have? We think let's say the hypothesis, training these women will dramatically change outcomes, right? At least in districts where we trained compared to districts where we didn't spend as much money training. Is there a comparator group, control group? And how long did it take to have an impact? Did it have an impact, right? Often very hard to tell because obviously the government of India also is focusing a lot on it. We are supporting the government in much of this technical support. So, data and, if you find out, well, maybe this is not working, maybe we should do slightly different, get feedback. So that is the approach often taken to mitigate risk, but absolutely the risk we take is significant. It is a complicated choice that has to be made. If you have passionate program officers who can make the case, well, then they convince the powers that be that this is worth funding.
Got it. It answered some of the questions which I'm not asking here. So
great.
Because some of the aspects which you mentioned about post response that have always intrigued me for last 2 years in COVID, that all the people infected by Delta or Omicron are not being hospitalized. And if they are hospitalized, they have very different subphenotypes. So what is driving that? There is one aspect of understanding the pathogens, genomes, and the information coded over there. But what about understanding the other host, which is by conservative estimates housing 20,000 genes and n number of non-coding RNA transcripts as well. So for all the reason which we know that human or the cells are the epitome of energy efficiency. So if something is being made in the cell, it must be made for some purpose. Now, whether they are playing a role in disease severity and outcome, it's probably the answer is not clear cut. It probably require more research, more disease phenotypes, more cohorts over a longitudinal scale, especially in the COVID times where a variant changes after every few months. So probably the outcome will not be as straightforward to count on the numbers, but probably that's why I'm in the prelude or the background on which why I asked this question.
Yeah. So I think, I mean, Aradhita and Rajesh, I think that unfortunately my talk is not very technical, right? It's sort of not really science oriented. So I hope it was useful for people.
It gives us a really
this
good
is
picture.
I know that
theme
you're
that we are
much more,
trying to introduce. Yeah.
yeah, you folks are much more science oriented. So, maybe, this is the one drawback of giving such a broad talk, but I'm happy I could be here. If there are any other questions.
If there are any other questions, could raise your hand or type it in.
I think
Whenever there is a call for those fellowship, couple of I would sensitize some of my students to try for it.
Sure, I'm happy to share it whenever it comes out. Hopefully it'll be big, it'll make some news.
Yeah.
So if there are no further questions, I'd like to thank Harish for being here with us and giving us an overview of how BMGF works and about all the initiatives and upcoming things. Thank you so much for your time.
Thank you very much, Harish.
Thank you so much. Only thing I feel bad is I was not there in person because I would have loved to see.
Would have been great.
The
Hopefully,
institute and actually meet, all of you who I've only seen on Teams. I think we've all seen each other on Teams, but